is the first time we are holding the lecture in the auditorium because we got the new auditorium for a separate function today. So I would like to thank you all for joining us today. So moving on to today's topic, it is bronchiectasis in children. And to deliver the lecture, we have with us Dr. Srimali Wijesundara, acting consultant pediatric pulmonologist, Teaching Hospital, Protracted. Yeah, madam. Over to you. You can have your time.
Good morning, all. Thank you for inviting me for this lecture. I'm working as an acting consultant, pediatric pulmonologist in Kuwait as well as India for 2 years. So I'm going to basically talk about bronchiectasis in children. Having said that, I'm not going to talk about bronchiectasis associated with cystic fibrosis. It's a separate topic altogether, so I'll be touching on non-CF bronchiectasis part mainly. So I'll be presenting a few clinical scenarios which I have encountered during my overseas training period. So this is case 1, we are going to discuss about a 12-year-old girl with a persistent cough for 1 year duration, presented with that symptom. So she has had about productive sputum with brownish speckles in her sputum as well, occasionally, and noted to have Haemophilus influenza in her sputum, and was treated appropriately with 2 weeks of Muco-active. But however, the cough persisted, so bringing up greenish sputum, was referred to the pediatric respiratory team. She is born at age, and there had been baby carrier stay for 2 weeks, mainly for feeding issues. And she also has had evacuation of diaphragm, which has been repaired at 14 months of age, and also fundoplication has been done, and there had been gastrostomy also inserted because of these feeding issues as well. That was early in life, and has had severe infection once, and that's about it in her clinical history. So there have been some concerns with hypotonia, where she has been followed up with the neurology team. However, she is quite okay in that aspect as well. So there's a history of mother having tuberculosis before the child has been born, obviously, and it has been excluded in her. So this was the CT that was shown in her when we have evaluated. So you can see that there are right middle lobe and right lower lobe changes with attenuated band that is going on. So this case has been picked up at 12 years of age. That's what I wanted to show. So we don't know how long she has had. We know that she has had about 1 year of ongoing cough, but we don't know how long she has been having that as well. So then she has been followed up appropriately for bronchiectasis. So in the case 2, I'm going to present about a 4-year-old child who was referred from, there's a GP system, so from GP, but this is going on for about 1.5 years, about 1.5 years, and the child was treated with antibiotics several times, and then started on asthma therapy as well. But throughout, it was noted that there were persistent changes in chest X-rays. And this child is also a termed baby who didn't have any postnatal complications, and growth and development has been quite okay. So there was just one hospital admissions-wise, about 1.5 years before this diagnosis. So child is quite well. This is just the ongoing wet cough, which has been a concern to the mother, and repeatedly seen by the healthcare professionals with the X-ray changes, to be seen by a pediatric respiratory consultant. It took about 1.5 years. This is UK situation, so this is from UK. So yeah, so there's a delay as well. So when we evaluated, there's obvious left lower lobe bronchiectasis seen in this child as well, and appropriately started management. In this case 3, it's kind of an interesting one as well, so not for the patient though. This one is a child about 10 years when I saw her. She was born in Italy, and they have evaluated her repeatedly for recurrent infections there as well. Since they have moved countries to the UK, so she has been followed up at Royal Manchester Hospital. Because of these recurrent respiratory tract infections, she has undergone flexible bronchoscopy and again shown to have increased influenza, was treated appropriately, and she was also having several other involvements apart from the lungs, noted to have lymphadenopathy and organomegaly as well, so appropriately evaluated for immune deficiency. However, the initial investigations for immune deficiency were normal. Because of these presentations and ongoing symptoms, further evaluation has shown a rare form of chronic granulomatous disease, which is P40 deficiency. However, that part has been cured with appropriate bone marrow transplant. But since these ongoing chest symptoms, she has been evaluated and noted to have this lower lobe involvement with severe bronchiectasis involvement in the left lower lobe. And for that, she required to undergo lobectomy at 9 years of age, and there are multiple occasions where she had developed hemoptysis as well, but couldn't find a bleeder. So she has been again managed appropriately, and she has grown pseudomonas by that time. So because of that, she is on regular IV antibiotic therapy as well. So this is just CT. So those were the 3 cases I wanted to draw your attention on. And so then when we talk about non-cystic fibrosis bronchiectasis in children, so this term bronchiectasis is rather an umbrella term. It's not, in itself, it's not a kind of a one disease, that it can happen with several causes. It can lead to bronchiectasis, so it's kind of an umbrella term that covers all these results leading to lung airway dilatation. So it's a clinical syndrome of recurrent persistent wet or productive cough and airway ongoing infection and inflammation of airways with abnormal bronchial dilatation on chest CT scans. So this, we know, like initially we heard that this is irreversible dilatation of airways, which is not the case mainly in the children, but not always. If detected really early and treated appropriately, these dilatational changes that we see in CTs can be reversible. So that is the most important part, because if we detect early and if we treat appropriately, these are reversible. So that is why we need to be more cautious and be able to detect these early. So this is also, there's not much of worldwide data on the prevalence of the bronchiectasis in children. So it has shown that in 18 to 19-year-olds, the prevalence has been increased from about 30 per 100,000 to about 44 per 100,000 people from 2004 to 2013 in the UK statistics. So we don't know what's happening in our context, but this bronchiectasis is not diagnosed as a rare disease anymore. But from the European Respiratory Society, it has been named as one of the most neglected lung disorders as opposed to many other lung disorders we talk about. However, this has a high individual disease burden, and which also reflects on economy and which leads to also poor quality of life in children, adolescents, as well as their parents are obviously affected when their kids are affected with this lifelong illness. So there are because we don't have much of a guideline as such, there are no updating guidelines, if I may say. So there are large disparities in standards of care as well between the centers in any country with children with bronchiectasis. Luckily, we have a local study which has been done in 2019 or so in our province by Dr. Anuradha and also Dr. Ganganath and with the supervision of Professor Mujita. So on that, they have evaluated about 52 children. So this is about non-cystic fibrosis bronchiectasis in children. They have mentioned about etiology, clinical profile and outcome in a single unit. So this is with about 52 children. So mean age at evaluation of these children was about 9.4 years, whereas the mean age at diagnosis was about 6 years, and mean delay in diagnosis is about 3.8 years, which means from a documented history of ongoing wet cough to the time of diagnosis as bronchiectasis, that is the delay we are mentioning. So this is, so we see that this has an 4-year thing like in here, but this is being the case worldwide kind of. So that is why we need to pay attention to children who are having ongoing wet cough, though they lose wet. So why do you think we need to detect this early? So this study shows that where they have evaluated about 182 adult patients and evaluated when they have started their clinical symptoms and found that the onset of these symptoms was in childhood in about 50% of this cohort. So, and other thing is, for each additional year of productive cough, it was noted to have a decline in FEV1 by about 0.5% even in non-smokers. So that is why we need to detect it early and to prevent this reduction in lung involvement. So if you think about when to suspect bronchiectasis in a child, so as we all know, ongoing wet cough with productive sputum and positive bacteriology as well. If you have positive sputum culture even in one sample for kind of an unusual organism like Staph aureus, Pseudomonas, or else local data fascia, and if there's obvious features of non-resolving pneumonia, persistent chest X-ray changes following treatment for low respiratory infection, and recurrent consolidations in your chest X-rays, then obviously you need to think about this as well. If your child has had previous specific infections like pertussis and adenovirus, mainly the serotypes 7, 14, and 21, also obviously the tuberculosis, then you have to think about suspect bronchiectasis. When we call atypical asthma, so if it's not tallying with your quite normal presentation of asthma, where you have diarrheal symptoms and where you have even exercise-induced symptoms, and mostly you have dry cough in asthma. So if it's not tallying with that, without going on treatment with cough variant asthma or something like that, just suspect this and try to evaluate more as well. Obviously, if you have a localized bronchial obstruction due to some lymph node enlargement or a mass or a foreign body or something like that, if there's a localized bronchial obstruction also, you have to suspect bronchiectasis. And if there's persistent crackles, mainly false crackles we would say, so then also better to evaluate. If there's hemoptysis, it could be upper airway, it could be lower, but you have like it's upper airway without bronchiectasis, but with the history you have to think about bronchiectasis as an ED also. If you have severe esophageal disease, like children who have tracheoesophageal fistula corrections, if you have obvious features of reflux, feeding issues, so when with your evaluation you have to think about your airways as well, because the airways are the things that get affected as well as your growth with all these feeding issues and aspirations. And if there's a family history of respiratory disease, as we asked about asthma, if they have these ongoing wet cough-like symptoms, so it has been diagnosed that there are several genetic involvements that leads to bronchiectasis, but those are not specific genes as such, but there are panels that they do in children with bronchiectasis as well if they suspect. If it's like, if there's a family history, then if you have facilities obviously, then you can see whether it's a genetically predisposed person to have bronchiectasis as well. Right. So I'm not going to speak in detail about the pathophysiology of bronchiectasis in this lecture, but I'm going to show this pathobiological model, which is taken from this seminal paper which has been done by Prof. Andy Chang, who's mainly involved with these bronchiectasis in children, who's a professor from New Zealand and Australia. So it was shown that how it evolves from this normal airway to your dilated airway to bronchiectasis from this ongoing wet cough. So we all have heard about this term I hope called protracted bacterial bronchitis, which came in light in about 20 years or so ago, and it was published in 2016, I think, by Prof. Andy Chang. So, where you have several categories which I will come into later. So, this is where you have a child who's quite well, not kind of playing around, and their feeding is not affected, nothing kind of, you can't see anything much wrong about the child, but there's this persistent wet cough which is worrying parents. Mainly they will have that in the morning, so at night as well, but it's not a dry cough, it's a productive cough, but children will not bring up the sputum, so they will swallow it, so you might not see the productivity, but you can hear it, it's a wet cough. And this can be treated, and then if this goes on without proper treatment, when I say when they have a wet cough, anyone will treat them, but maybe about 3 or 5 days of antibiotics, so that might not be enough in these children. So this will go into chronic suppurative lung disease, where you don't have this dilatation of bronchi, where you have the bronchiectasis part, and then it will lead into a radiologically confirmed bronchial dilatation and bronchiectasis. So this is the way that it evolves with bronchiectasis. So few things about protracted bacterial bronchitis and bronchiectasis at the end as well. So what is this? This is ongoing wet cough going on for about more than 4 weeks. But I should say that you don't have to wait till this 4 weeks. I know that the diagnosis comes at 4 weeks, but if it's going on for about 2 weeks and 3 weeks, and then you have to think about this and better to treat early. And then if with the microbiology PBD micro we call it, then we have a positive bacterial culture with a respiratory pathogen, and then it responds to your 2 weeks course of mainly Muco-active. So when you have all these three things, this is the ongoing wet cough which responds to 2 weeks of Muco-active mainly, and there's a positive bacteriological culture, we call it the classic PBD or PBD micro. And then we have an entity called PBD clinical where you don't, you have all the other things, but you don't have the bacteriological culture, because obviously if you don't do a BAL, you will not see the bacterial growth as the children will not fill up the street. And you call PBD extended. This 2 week course of antibiotics will not resolve this wet cough, so you may need further 2 weeks of Muco-active to cure this cough. So then you call it PBD extended. And you can call PBD recurrent when you have more than 3 episodes per year of these ongoing wet cough, like all of these persistent bacterial bronchitis episodes within a year. And you call CSLD or chronic suppurative lung disease where you don't have HRCT findings. When you have HRCT findings, you call it bronchiectasis. So this is how it evolves. So that is why I'm saying repeatedly, so treat early to cure at that time. So when we diagnose a child with bronchiectasis, when we suspect a child who's having bronchiectasis, so what are the tests or the minimal panels we have to do? Obviously, you have to diagnose by a chest CT, and then you have to evaluate their lung function tests if they are about more than 6 years of age, and see their baseline mainly, and also to exclude cystic fibrosis, go ahead with the sweat test, obviously the full blood count and basic immunological investigations, and you can go ahead with the Airway assessment with the BAL to look for low airway bacteriological pathogens to treat. So when you have prevalence of tuberculosis and HIV, which is not high in our setup though, but we have a significant amount of tuberculosis in our society, so we have to think about these as well. And in selected children, with, according to the clinical presentation, we have to go ahead with in-depth immunological assessment rather than basic ones, and obviously bronchoalveolar lavage and bronchoscopy to see the airways as well as collect the samples. And if you think about that they are having recurrent aspirations or GORD symptoms, then you have to evaluate accordingly for your by doing your soil assessments, pH impedance, and those things as well. Then if you suspect primary ciliary kinase, where you can have sometimes dextrocardia, and as a neonate, if a term neonate who has had respiratory symptoms and who requires ICU care like for respiratory issues, then and ongoing upper airway symptoms, or else the family history, with all these clinical scenarios, you can think about primary ciliary kinase as well. So we don't have definitive tests or genetic tests at the moment, or ciliary brushings, but we can see the nitric oxide if it's less than 70 particles per million. So then you can suspect that. But with the given clinical history also, you can think about that. And obviously the GORB, you can think about that. So this sort of shows the same thing in a simplified way, where you have to evaluate according to the involvement or according to the history of the child's symptoms. So again, if you think about the diagnosis, so high resolution CT with multi-detector CT, they say, rather than the conventional CT. You have to do that to diagnose bronchiectasis in children and adolescents. So as opposed to adults, where you go for different cutoff levels of air dilatation, in children it is its involvement is the dilatation is with the lesser amount of dilatation we diagnose bronchiectasis in children as opposed to adults. So bronchoarterial dilatation, we see the dilatation of bronchus with the adjacent artery, size of the adjacent artery, artery's outer diameter and the inner diameter of the adjacent bronchiole. So if the ratio is more than 0.8, then we detect bronchiectasis in children, but in adults it's just 1 to 1 or 1 to 1.5 ratio. So we have to keep that in mind as well. So we'll move on to the management. I'm going to discuss the management with these guidelines they have put forward in 2021 by the European Respiratory Society for the management of children and adolescents with bronchiectasis. So what are the objectives of management? Obviously to optimize lung growth, because they are having, their lungs are growing. Also to preserve lung functions, to have a quality life towards the adulthood, and then to minimize exacerbations, that is a major part of your management. Then to prevent further complications which can arise with this bronchiectasis, and if possible to reverse this lung damage if we detect early in the course of illness. So what are the specific treatments? When we think about specific treatments, there's no cure as such, obviously. If it happens, if we detect early, yes, it's reversible, but there's no cure as such. But specifically, we can address these exacerbations. So for acute exacerbations, you can start either with oral or IV, according to previous bacterial growths, and with the prevailing organisms in your setup as well. And you have to be cautious about the duration, because they may need, as I mentioned, they may need prolonged courses rather than just short courses, about 2 to 5 days or even 1 week. They might need about almost 2 weeks course of antibiotics to get rid of these exacerbations. And if they have Pseudomonas growth, are we going ahead with eradication therapy? If it's a new growth, because this has been previously, this has been evaluated and researched in CF population. So are we going to just go ahead with that? You have to consider in each and every patient kind of individual basis. So, but you have to look out for Pseudomonas as well in this picture. So for maintenance therapy, are we going ahead with azithromycin? So they have recommended to use azithromycin, which was in the research, it was once a week, 30 milligram per kg, which we give in 3 doses, like either once a week 30 milligram per kg or 10 milligram per kg, Monday, Wednesday and Friday, so like 3 days per week. So we can use that to prevent further infections. however, having said that, this is mainly for children who are having repeated exacerbations, like more than 3 exacerbations per year, right? So it has shown to have a benefit when we use it for about 6 months. And if you are planning to continue to use it more than like 1 to 2 years, then we have to re-evaluate, reassess and see whether this child is really benefiting from this. Sometimes, though we don't have like seasons like winter and stuff like that, but sometimes we can think about like what time of the year they mainly have these infections, and think about having a chunk of that that period to have this prophylaxis, and then have time off that as well. So you have to consider it individually. And this is the like a salient thing in management. Mainly you have to do the airway clearance, because we know like when you have the dilated airways, your mucociliary escalator function is not properly happening, so then your mucus will stagnate, and on top of that there will be biofilm formation of the organisms, and then you will get infections because you can't clear that up or you can't treat it properly. Then it will lead into further airway damage. So that's why we need to have proper airway clearance techniques. So I have shown here a graph showing like what can be used. So positioning can be used with gravitational airway drainage, and also expedited flow modifications you can use. So in like little children, you can use blowing games, and we use, obviously here you all must have seen what we use, the bottle pep devices, where you have this oscillatory effect, so you have oscillation as well as post expiratory pressure as well. So with that also you have to use this huffing and puffing mechanisms following these techniques just to clear up your airways. And there are instruments, those things are not much available in our setup, but obviously our bottle pep device also gives the same kind of results, and you have to be cautious about the water they use. If it's like kind of a stagnant water and it's kind of contaminated, that's the only main thing you have to think about when you're using the bottle pep. So I hope you all know like what we use. It's a very simple thing that we use. You ask them to use a mega bottle or something like that, and use some water to a level of about 10 to 15 milliliters, and then you ask them to buy a clear hose, we call, from a hardware, obviously. Null to never, so that's the diameter you go for. You ask them to have about 1 to 1.5 meter length, and then you put it inside this water, and then you ask them to do the bubbles, blow and make bubbles. So that is where you get this oscillatory pep effect. And following these cycles, so you ask them to do 10 times of this, and then you ask them to do huffs, where you open up and dislodge your mucus, and then 3 huffs and 3 coughs and you clear off. So you ask them to repeat these cycles, about 10 cycles in the morning as well as in the afternoon, and can go to 3 times per day when they have an acute exudation as well. And apart from that, you can have, when you don't have much of neuromuscular power, when you have when you are neurologically affected, you may need to use these devices like vests, where you need to have the dislodgement needs to be done mechanically, and then we call cough assist devices, where you don't have proper effective cough when you use these cough assist devices. And the green one is called third device where you use it to clear the airways, mainly when you have acute exacerbations. So you give a positive pressure with that, so their airways clearance can be augmented with these devices. Right. So apart from that, so these are the measures that can clear the airways. So to facilitate this clearance, you can use muco-active agents. So most commonly used ones are hypertonic saline, as we all know. We also use that. So hypertonic, when we say hypertonic saline, it could be 3% or 7% even. So we don't have much of high quality randomized control trials in children, but in our setup previously one has been done as well. So other agents like mannitol, like oral N-acetylcysteine, carbocystine, and those things has been used in several places, but there are no adequate evidence to support these things. And the pulmozyme or the DNA sensor that you use for cystic fibrosis, which cannot be mainly used in bronchiectasis children according to the previous data, because it has shown that though it is useful in cystic fibrosis, so it has shown that it's mainly harmful rather than beneficial in children with non-severe bronchiectasis. So this is the local study which has been done, the same study I have mentioned previously, which has shown to show the effectiveness of hypertonic saline nebulization in airway clearance in children with non-cystic fibrosis bronchiectasis. This has been done as a randomized controlled trial. So this has shown that children who has used the hypertonic saline has shown higher mean improvement on predicted FEV1 after their phase 1 and phase 2, where they have like two groups, and which has done as a crossover study with a period of washout as well. So in these both phases, it has shown an improvement of FEV1, and mean number of exacerbations has been shown to be lower in phase 1, but it was not shown in the phase 2. So this is a start, so I think we need to have further more studies as well in this aspect. And so what about the asthma-based therapies? So if they have coexistent asthma, or if they have reactive airways, only they can use asthma treatment, otherwise there's no suggestion for that. So other than that, other NSAIDs and statins and all those things, though has been started to evaluate, no data on those things. So you need to go ahead with surgical options, as I have mentioned in one case previously. So if it's a kind of a main involvement with a single lobe, so you can think about having a lobectomy if they have poor control of symptoms with ongoing puffing sputums and frequent exacerbations, which is affecting the optimal medical care, or as they are not having a proper growth despite the proper treatment. Also, severe hemoptysis where you can't find a bleeder, then obviously with these indications you can move ahead with the lobectomy where it is kind of almost curing the thing, but you have to be cautious because these kids are just growing still, and if we like remove a chunk of their lung, so then there are issues like scoliosis and things that will come hand in hand with that. So you have to be decide upon these things on individual basis. So other thing I want to mention is that it's mainly beneficial to have like tailored plan for each and every patient with bronchiectasis, where you will not be managing him in your tertiary center all the time, and sometimes they may not need to come to your attention. They can kind of start treatment initially at home if they were well informed. So better to have a tailored plan for them, including their airway clearance techniques and their nebulizations, and also what to do if they do have an exacerbation. And obviously, like any disease, so general care should be think about nutrition. So as always, vitamin D deficiency and micronutrient deficiencies you have to think about. So we can ask them to do more physical activity rather than just just staying inside and not doing anything. So we know, like, if they do kind of exercises like running or jumping on a trampoline or a football or something, so then it will help in their airway clearance as well. And so obviously tobacco and environmental pollutants we need to avoid. Think about immunizations, additional ones rather than the routine ones, like influenza or pneumococcal vaccines. So since this is a disease that is going on for life and they have recurrent exacerbations, so they need the children as well as the families need psychological support. Think about that aspect as well. So I have briefly mentioned about persistent bacterial bronchitis and its management. So the antibiotics based on the local guidance and local organisms, mostly used Muco-active or amoxicillin clavulanate, because it will cover most of the pathogens that has been identified in these children. So main thing is treat at least 2 weeks and see the response, and you may have to extend it for 4 weeks. So in these given situations, don't be afraid of the antibiotic usage or resistance organisms or anything like that, because you have to protect your lungs first, okay? And in these children, there's no data to mention about the maintenance azithromycin or treatment azithromycin. If they are obviously allergic to that corticosteroid, you can go ahead with azithromycin, I suppose. So sometimes if it's ongoing and they have like tracheobronchomalacia, like structural things, you can think about the airway clearance techniques in these children during exacerbations as well, but there are no suggested data on those things. So how is the prognosis? So the outcome is very different to adults because in adults it's like it has gone on for some time, so they have other comorbidities as well. But as opposed to that, in children, if we detect early, as I mentioned, it is reversible, not in adults. But and in adults, they have mentioned poor prognostic indicators, so they are lung function, low lung functions, prevalence of pseudomonas, and also reduced quality of life scores. If those are there, that means their prognosis is reduced. So in children, for lung function decline, the sole factor is these recurrent exacerbations. So you have to detect those early and treat appropriately. So to detect those, you can't be staying till they develop fever and they develop systemic symptoms. So these children, they will have very subtle symptoms because they have this ongoing wet cough, they have a baseline cough, they have baseline lung signs as well. So you can't just go with that. But if this cough pattern changes, if you have more productive sputum, if you have color changes in this sputum, sometimes they may have some subtle changes in the appetite as well. And then they will feel some chest pain sometimes. If there are localized lobes involved, some children will come out with some pain and stuff as well. So these subtle changes, because they know, like, because they live with the disease, so they know their changes, and parents know if there's a change. So you have to be very vigilant and pick up those cues, and then start treatment early as an exacerbation, because it's no use waiting till the end where they develop high fevers and when it's going to systemic involvement. So deaths are rare in children as opposed to adults, but they have detected few deaths in New Zealand and also in UK in like last 10 years or so. So I'm sure if we don't detect early, if they have exacerbation, then obviously they will also will go into these unfortunate outcomes. So what are the take-home messages? If you have a child with ongoing wet cough even for more than 4 weeks, it's not a normal thing. So it's normal to have a runny nose, ongoing runny nose. It's normal to have like then and there infection, then and there, like few days cough, and then that would be okay. But if they do have a wet cough which is ongoing for about 4 weeks, then you have to be very cautious and you have to treat early and then evaluate early. So though you have detected bronchiectasis in your CT, don't stop there. Just evaluate further to find the cause, because this is just an umbrella term, so this should fit into some diagnosis as such, why it has occurred. So then you have some definitive treatments in some diseases. So with early detection, it's reversible. Can't stress more than that about that, right? So there's not much of quality evidence on management of this disease in children mainly. So there's more scope for research on this. So thank you very much. Any questions?
How common and how the prevalence is of how about this?
Yeah, that's because there's no data. There are no data in our setup even, and worldwide also they don't have data in children, unfortunately still. So that's what I said. Like in about like teenage and about early 20s, like those age group they've done. It's about 44, 45 per 100,000, but we don't know the prevalence in our kids or even worldwide in that much. Unfortunately, that's what I said. Like, there's a real gap there. But however, the detection is kind of increasing, so we are more aware and we are looking out for that as well. So yeah. Thank you.